Hello and welcome to our new topic. Today we will discuss sedative and hypnotic drugs, a group of agents widely used in clinical practice for anxiety, insomnia, seizures, anesthesia, and withdrawal states. We will integrate neurobiology of sleep with pharmacology, compare older and newer drugs, and finish with a rational approach to hypnotic selection and safe weaning. These drugs carry significant risks, making a deep understanding essential for all clinicians. So, let's start. The learning objectives are shown. Please take a look. By the end of this lecture, you should be able to classify sedative hypnotic drugs, explain their mechanisms of action and receptor selectivity, understand their pharmacokinetics, and recognize their clinical uses and adverse effects. Importantly, we will also focus on how to safely taper and discontinue these drugs in long-term users. A sedative reduces anxiety and calms the patient, while a hypnotic induces sleep. The distinction is not absolute. Most sedatives become hypnotics at higher doses. The majority of these drugs exert their effects through GABA, the most important inhibitory neurotransmitter in the CNS, acting primarily at GABA-A receptors. This slide emphasizes that sleep is a biologically regulated process rather than a passive state. Poor sleep has wide-ranging effects on cognition, metabolism, mood, overall health and immunity. Understanding sleep biology helps us choose drugs that correct the underlying disturbance rather than simply sedating the patient. Normal sleep progresses through non-REM and REM phases in cycles throughout the night. REM sleep is important for memory consolidation and emotional regulation, while growth hormone is released predominantly during deep non-REM sleep. Drugs that markedly suppress REM sleep, such as barbiturates, therefore disturb normal sleep architecture. This diagram highlights two opposing systems. Melatonin promotes sleep onset, particularly in darkness, whereas orexin maintains wakefulness and stabilizes arousal. This dual system model explains why melatonin agonists help with sleep initiation and why orexin antagonists work for sleep maintenance insomnia. Modern hypnotics increasingly target these systems, melatonin agonists for circadian rhythm disorders and orexin antagonists for hyperarousal-related insomnia. Sedative hypnotics can be broadly classified based on their molecular targets. The largest group acts on the GABA-A receptor, but newer agents work independently of GABA, offering improved safety profiles and reduced dependence. This slide illustrates that CNS depression occurs along a continuum. Benzodiazepines demonstrate a ceiling effect, making them relatively safer, whereas barbiturates show a linear dose-response curve that can progress to coma and death. This difference explains the decline in barbiturate use. It reinforces the concept that sedatives and hypnotics are not separate drug classes but dose-dependent effects of the same drugs. Clinical judgment is therefore essential when titrating doses. The GABA-A receptor is a ligand-gated chloride channel. When activated, chloride influx hyperpolarizes neurons, reducing excitability. Sedative hypnotics enhance this inhibitory effect through different mechanisms. Barbiturates, benzodiazepines, and Z-drugs all act at different regulatory sites on the GABA-A receptor. Their differing receptor interactions explain variations in safety, duration of action, and clinical use. Barbiturates are pyrimidine derivatives that increase the duration of chloride channel opening at the GABA-A receptor. They also suppress excitatory glutamate transmission. Because they cause profound CNS depression and lack a specific antidote, their use as sedatives or hypnotics has largely been replaced by safer agents. Barbiturates are classified by duration of action. Thiopental is ultra-short-acting and used in anesthesia induction. Short-acting agents were once used as hypnotics, while the long-acting phenobarbital remains important as an anticonvulsant. These drugs cause dose-dependent CNS depression, producing sedation, hypnosis, anesthesia, muscle relaxation, and anticonvulsant effects. They reduce REM sleep and can cause anterograde amnesia. Tolerance develops rapidly, and cross-tolerance with alcohol is common. Sudden withdrawal is dangerous and may cause tremors, anxiety, seizures, delirium, and even cardiac arrest. This slide contrasts benzodiazepines and barbiturates. Benzodiazepines increase frequency of channel opening, whereas barbiturates increase duration, partly explaining their greater toxicity. The pharmacokinetic parameter like distribution or redistribution is the main reason for the rapid onset and short duration of action of ultra-short-acting barbiturate thiopental. The underlying reason is its high lipid solubility that enables the drug to leave CNS and get redistributed to lipid depots. Barbiturates are metabolized in the liver and excreted more rapidly in alkaline urine. Some barbiturates have active metabolites in addition to themselves being acting, explaining a long duration of action. Long-acting drugs cause hangover and daytime somnolence, while short-acting agents may cause daytime anxiety. Cognitive impairment and reduced psychomotor performance are common. Chronic use leads to enzyme induction, increased drug interactions, worsening of acute intermittent porphyria. CNS depression is more pronounced if other CNS depressing drugs are concomitantly used. The addiction is a problem and is characterized by a withdrawal syndrome if intake is suddenly stopped without weaning. At high doses, barbiturates depress respiratory and cardiovascular centers, leading to death. Hypersensitivity reactions and accidental poisoning may also occur due to impaired judgment and forgetting an already taken dose. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!